The remainder of the course provides a broad introduction to economic evaluation of health programs, how these evaluations are used to inform policy and decision-making, and should provide a basis for understanding and appraising these evaluations. In the previous section, you were introduced to the field of health economics, which includes many subdisciplines. One of our learning objectives is to teach you to use an economic evaluation in the assessment of a health issue and proposed intervention options. This is achieved using microeconomic evaluation methods, box E in the Williams-Plumbing diagram. A formal definition of economic evaluation is the comparative analysis of alternative courses of action in terms of both costs, resource use, and consequences, outcomes, or effects. This definition is found in the definitive textbook on health economic evaluation, authored by Drummond et al., and commonly referred to as the Blue Book. The reference is provided in the reading list. In the context of health programs, alternative courses of action may involve comparing standard of care to a new intervention or technology, such as a new drug. There are 4 main types of economic evaluation, and they differ in how health outcomes are measured. Cost-minimization analysis can only be used if the outcomes are assumed to be equivalent for the interventions being compared. In this case, only costs are considered, and outcomes are not measured as they are equivalent. This type of analysis is rarely conducted. In a cost-benefit analysis, the outcome is expressed in dollars or monetary units. This method may be used widely in other sectors, but is less commonly used in healthcare as it can be conceptually difficult to associate health outcomes with monetary values. This type of analysis is also rarely conducted. In a cost-effectiveness analysis, any natural health unit or health outcome can be used. These types of outcomes may be very clinically relevant, or it may be in context where a particular disease is prioritized. In a cost-utility analysis, the outcome used is the quality-adjusted life year, or QALY. A QALY is comprised of life years weighted by health utility. Health utilities and QALYs will be further explained shortly. This type of evaluation is usually required by health technology assessment agencies. We will now illustrate each of these types of evaluation with simple examples. A cost minimization analysis, or CMA, is based on the understanding that the interventions being evaluated lead to equivalent outcomes. In this case, only costs need to be evaluated, and it is presumed that the least costly intervention would be preferred. For example, a CMA could be used to examine the cost consequences of administering an IV drug in a hospital or a specialist's office. The outcomes are similar, but the costs would differ. In this case, the specialist office is the least costly setting and therefore likely preferred. Note that this example could become more complicated if costs to the patient have been included. In this example, we are only considering the healthcare perspective. The perspective taken refers to what costs are considered in the analysis and will be discussed further in the next section. Cost-benefit analysis, or CBA, values outcomes in monetary units. While this method is widely used in other sectors, it is less commonly used in healthcare due to challenges in valuing health gains in monetary terms and potentially difficulties in double counting costs and benefits. The results of a CBA can be presented multiple ways. The example table shows that results of a CBA can be presented as ratios of benefits to costs, net present value, which is the difference between benefits and costs, and incremental net benefit. It is helpful to be familiar with these different expressions. However, as CBA is rarely used, we won't drill down further on these different reporting methods. A cost-effectiveness analysis, or CEA, uses outcomes in any natural health unit that are meaningful to the intervention. In our simple example, we are looking at 2 drugs with different efficacy in terms of how many symptom-free days they yield per month. The more expensive version of the drug has better efficacy, that is, more symptom-free days. The findings of this analysis are presented as an incremental cost-effectiveness ratio, or ICER. This is the difference in costs divided by the difference in effects. We will learn more about this ratio and how to interpret it in a moment. In this example, the ICER is $4 per symptom-free day gained. We then need to think about how much we are willing to pay to gain a symptom-free day and whether this cost represents good value for money. This can be difficult to consider for individual or unique natural health units, like a symptom-free day. The challenge with understanding the value for money of gaining natural health units, which are used in CEA, has led to cost-utility analysis, or CUA, being the method of economic evaluation that is most preferred by health technology assessment agencies. CUAs report health outcomes as quality-adjusted life years, or QALYs. The QALY is a synthesis of quality of life, or health utility, and life expectancy. Health utility is typically scored on a scale from 0, representing death, to 1, representing perfect health. Any health state or outcome can theoretically be expressed using a health utility value. Valuing health outcomes in a common metric, such as a QALY, enables comparison across different health interventions and a clearer understanding of the value of the health gains. If we look to our same example as we used in the CEA, and rather than valuing effects in symptom-free days, but instead use QALYs, we can see that this would lead to an ICER of $200 per QALY gained. Typically, willingness to pay thresholds are established for QALYs so we can understand whether the gain in QALYs represents good value for money. We will go into more details on QALYs and willingness to pay soon. While QALYs are generally the preferred metric for quantifying health outcomes in an economic evaluation, this may not always be practical or feasible. The benefits of using QALYs is that they encompass many aspects of health status, and they allow for comparison of health gains across different types of programs. But there are drawbacks to using QALYs. They may be difficult to interpret or validate in real life, and gathering health utility data may be challenging. Proxies may be needed to assess health utility in populations that are unable to self-report, such as people who are disabled or infants or children. We will learn more about how health utility data is gathered in the next section. The Disability Adjusted Life Year, or DALY, is an outcome that may be used in international contexts and is often used in economic evaluations conducted in low and middle income countries. The DALY burden for a particular condition is the sum of years of life lost due to premature mortality, or YLL, and years of life lost to disability, or YLD. Health interventions seek to avert DALYs, and in doing so, to increase the number of years that a person lives in good health. We have introduced this term so that learners are familiar with it, but we'll continue to focus on QALYs in this course. When we introduced CEA and CUA, we talked about reporting the findings as an ICER, an incremental cost-effectiveness ratio. An ICER is a ratio of the difference in costs, i.e. the incremental costs, divided by the incremental benefits. The formula is shown here, and we will work through some calculations as we go through the module. The incremental cost-effectiveness ratio yields the cost per outcome gained. If the ICER is less than what we are willing to pay per outcome gained, we conclude that the new intervention is cost-effective. This is not the same as saying it is cost-saving. In general, you pay more to get more. This can be more clearly visualized if we consider the ICER within a plane, where costs are on the y-axis and outcomes are on the x-axis. This plane has 4 quadrants. The dotted line represents our willingness to pay. If the new treatment falls in the northeast quadrant under that line, we deem it cost-effective. We are paying more money but realizing health gains, as in our example where the more expensive drug led to more symptom-free days. Interventions are rarely cost-saving, i.e. falling in the southeast quadrant of the plane. An example of a cost-saving intervention may be a vaccine which prevents serious illness. When a new intervention is both less costly and more effective, it is said to be dominant. Rarely would we choose to adopt interventions that are less expensive but also lead to worse health outcomes, which would fall in the southwest quadrant. If an intervention fell in the northwest quadrant, the new intervention would have higher costs and worse outcomes than the existing treatment, and the existing treatment would therefore be dominant over the new treatment. In Canada, our willingness to pay to gain one QALY is typically $50,000 to $100,000, although this is an informally adopted threshold. In Canada, $50,000 to $100,000 per QALY gained is informally considered cost-effective or good value for money. If our budget for healthcare is unlimited, then the willingness to pay threshold can reflect what we think the value of a QALY is. In Canada, the healthcare budget, however, is limited. Thus, if we fund a new intervention, we will need to disinvest in other interventions for other conditions. The willingness to pay threshold should reflect the QALYs lost by diverting resources from currently funded interventions to any new interventions. If the ICER for a new intervention falls below this threshold, then funding the intervention will produce more QALYs than the interventions for the other conditions we would need to give up. The health of the population will increase. If the ICER for a new intervention lies above this threshold, then funding the intervention will produce less QALYs than the interventions for other conditions we would need to give up. The health of the population will decrease. Other factors may influence technology adoption following a recommendation or a finding that a technology is cost-effective. Funding decisions are also based on budget impact, implementation feasibility, equity, and efficiency, which are often not sufficiently addressed in health technology assessments. There may also be questions of political will, the nature of the intervention, whether it is life-saving versus life-extending, which patient groups are affected, and more. We will go into further detail on health technology assessment in a later section. There are a few key takeaways from this section. There are 4 main types of economic evaluation that differ in how they consider outcomes. There is the CMA, in which outcomes are equivalent between interventions, the CBA, where outcomes are valued in monetary units, the CEA, where outcomes are valued in natural health units, and a CEUA, where outcomes are valued using QALYs. The QALY measure combines life expectancy with quality of life, typically measured using validated survey tools, which we'll cover in a future section. CUA is the preferred economic evaluation type as it reports health outcomes in a common metric. Decision makers can therefore compare costs per QALY gained and determine whether the incremental cost represents good value for money. In the next section, we will learn how economic evaluation models are structured. This concludes Section 1, Part 3. Please proceed to Part 4. How do you conduct an economic evaluation?